Bienvenidos and welcome to the inaugural episode of Puentes, your bridge to all things primary care in New Mexico. I'm Mario Lozal, and I'll be your guide on this journey where we hear from the people that make primary care special in our beautiful state. On today's episode, we trace the 10-year journey of the New Mexico Primary Care Training Consortium. From its humble beginnings to its vision for the future, there's no better way to kick off Puentes than by building a bridge to the past and future with the help of our esteemed guests, Dr. John Andazola, ex-president of the Executive Board of Directors, whose leadership steered the consortium through its formative years, and Dr. William Mack Bowen, the torchbearer leading us forward. Together, they'll shed light on a decade of commitment, challenges, triumphs, and the road ahead for the NMPCTC and primary care in New Mexico. So whether you're on the open roads of our state, cozy at home with a cup of Piñón coffee, or anywhere in between, let's cross this bridge together. This is Puentes. Gentlemen, how are you today?
Great. Excited to be here. A little nervous, but good to go.
Doing well. Thanks, Mario.
Excellent. So really quick, if you can give us an idea about your backgrounds and how you became involved with the consortium.
That's a good question. So I'm John Andazola. I was actually born and raised here in New Mexico, and I am the recent past program director of the Southern New Mexico Family Medicine program in Las Cruces. And, that's really kind of how I got hooked up with the consortium. Wow, Mario, do you want me to tell you the whole history and how I got hooked up and how that works and stuff? Because I could. So, I'll tell you a little bit, and we could come back to it and get into some depth. But initially, all program directors, and they still are members of the New Mexico Academy of Family Physicians board of directors, and we would meet quarterly with the New Mexico Academy of Family Physicians, and the program directors would break off and kind of have their own little meeting to talk about their programs and how things were going, talk about struggles, etc. And Charlie Alfaro knew about that. And Charlie Alfaro has been, quite frankly, an incredible asset to the state of New Mexico in rural medicine. And he was really thinking about how he can help develop and sustain programs throughout the state. And he approached the program directors that were meeting regularly and said, hey, let's get this formalized. Let's get this formalized into its own organization. And let's do some planning and some organization where we can help the programs that exist to be sustainable and then help develop new programs. And his insight was that if you can train a doctor in a community, they're likely to stay in that community. And so, what can we do to do this? So in 2010, he sustained a grant that was the seed money to start this consortium. And that's kind of how I started, and that's kind of how that's how I got connected. So just been part of the program ever since. We did some mission vision, that sort of thing initially, goal setting initially, and then he convinced me to be president. So I was the guy who didn't say no, and was the founding president, and basically until this year. So and it's exciting to think about where we've come from since then. So
my history will be shorter because I've been part of the consortium for 4 years now. Originally, I'm a New Yorker, so I'm a New Mexico transplant. Which has been just absolutely beautiful, learning about the culture and the history, and as a director. And so I got hooked up with the consortium in 2019 when I was identified as kind of stepping into the PD role under the mentorship of Dr. Regales, who was also one of the founding members and prior program director of our UNM Santa Fe program. So when I started to get more involved and was rising into the PD role, he said, you should be a part of this consortium. Um, didn't really know what I was getting into in terms of what it was all about. But under the mentorship of John and others like Dan Waldman, and Charlie Alfaro, of course, have just been learning more about the mission and participating in meetings over the years, networking with all of the folks who make up the consortium and kind of our ally partner organizations, and have been absolutely loving the work. And so, because I absolutely share the passion of Dr. Andazola and the founding fathers, I have run for the position of board president, and I'm very happy to become more involved in the inner workings of the consortium.
One of the things that you mentioned was just this idea that, you train the doctors here, they stay here. Was that always kind of the main goal of the consortium?
So the AAMC, and I don't even know what that stands for, Association of Medical Colleges, American Association, I don't know. But the AAMC every year tracks residency medical school graduates and tracks where they go to practice in their initial year. And this is decades old data, and year after year after year, they show that physicians tend to stay where they graduate residency. And really the big one is if you graduate residency, there's about a 50% chance that you're going to stay in the state or within a 100-mile region, depending on how you look at that data. If you graduate medical school, it's only about 35%. But what's interesting, if you graduate medical school and residency in that same community, there's like a 70% retention rate. Now, different specialties have higher retention rates and other specialties have lower retention rates, and family medicine tends to be about a 60% retention rate, and I'm proud to say, like, the residencies that Mac and I both are associated with in Santa Fe and Las Cruces have retention rates that hover around 70%. So, it's been demonstratable nationally, and it's definitely been demonstratable and reproducible here in New Mexico. And so with that knowledge, I think Charlie Alfaro, who is really the founder of this organization, was thinking, gosh, how can I get docs training in my community? How can I get docs training in Silver City and Espanola and in Hobbs, and instead of just the main cities along the Rio Grande corridor? How can I get these docs in these communities? And knowing that data, he was like, let me build those programs. And so part of that was developing the New Mexico Primary Care Training Consortium to really think about how we do that and take some strategic steps to do that. So I'm going to tell you a story about Charlie, and it might be true. It might not be true. I've heard this story, and I've not ever heard it refuted. But Charlie Alfaro is from New York City, and he came out west to get educated and settled in Silver City, and has lived in various places throughout the state. But the story goes that one day he was traveling through Lordsburg, and he was ill, and he needed to see a doctor. And so he pulled over in Lordsburg to seek medical care. And they said, no, we don't have a doctor. He goes, well, you have like a hospital. And they're like, yeah, but we don't, it doesn't work. It's not functional. We don't have doctors. In fact, the whole county has no physicians. And he started Hidalgo Medical Services in Hidalgo County to have doctors there. And it grew into a large federally qualified health center, not only in Hidalgo, but also in Grant County, and was a very impactful organization that he headed up. And then he had difficulty retaining physicians and recruiting physicians, just like everybody does to small communities. And he knew about this idea and started a residency in Silver City, New Mexico, that was associated with the same time we grew the NMPCTC. And it's like, the vision of really getting doctors to care for these communities that have nothing. And not only that, it's the vision of not only having a place for people to work, it's training the physicians in those places and they stay there and they grow that. And I think it's a great story. And Charlie just smiles and kind of like ignores me when I talk about that. But whether it's true or not, I don't know. But I think that's our vision. Let's how do we get docs to these communities to serve these communities? And I think that's really the crux and where the rubber hits the road and what we're trying to do.
I love that story, and I believe every ounce of that, because Charlie's one of those guys that once he has an experience that's informative, puts his mind to something and creates a vision and makes it come true. So I believe every word. I would echo a lot of John's sentiments that a lot of the incentives are to really keep docs in these academic ivory towers in big cities. And graduate medical education, GME for short, you might hear us allude to, the funding and finances are all perverse, and they don't make much logical sense. They don't get updated frequently. Congress doesn't pay much attention to these issues. And so the staying where you train thing is very much an entrenched financial system. Institutions like academic centers don't have any incentive to allow their residents out into rural communities to do an audition rotation. Oftentimes they need their service, all the time to make the hospitals go. And so you only see what you know, and less as healthcare becomes an employed field rather than a self-employed field, and less docs are willing to hang a shingle just because it's so complicated to start your own business in healthcare now. More and more docs are employed by these large health systems, and increasingly those are in cities, and rural communities are put out. We do need to break out of that model. And as John alluded to, we have much better success than large urban centers in getting folks into rural practice. So, we're laser focused at trying to figure out how to break down those barriers for the communities that can engage in residency education. For those who can't, how do we get residents to pay attention to those communities as well, and think outside of the box in supporting these community-based programs? Because even with an academic affiliation, it's hard enough to staff, to attend, to provide high-level curriculum and educational experiences that fulfill the ACGME requirements. And so the consortium has a lot of institutional knowledge that's very place-specific. It's very specific to overcoming these shared barriers that we have regardless of what corner of the state we're in, and tap into that hive mind and institutional knowledge now with all this history. We all have common barriers in training residents, and hearing how Dr. Andazola and Dr. Waldman and Regalis and Nelson had done them before can help new programs and existing programs to get around some of the challenges that we all share. So it's been an incredible resource for me and other young leaders coming up to try to get around certain challenges.
Yeah, that's very interesting, because I know, I'll say from my time, I've been with the consortium for 2 years. And in that time, one of the struggles, I think, has been kind of maintaining these residencies, right? So like we have residencies that are open and they're in rural parts, and then we see them close, unfortunately. But then, there's always this drive, to bring that residency back. And I think that's something that is definitely a valuable part of what we do.
No, absolutely. Yeah. I think everything that Max said was really, it hits the nail on the head. A big part of the consortium is bringing resources to a resource poor area, enough resources to a resource poor area so that they can train physicians there. Because it's hard, right? So if you're an academic medical center, you have you have a depth that of resources that you don't have in a rural hospital, right? Or a rural FQHC, right? And so trying to find those academic resources, well, where's your statistician, or where's your library services, or sometimes it's basic stuff like somebody to talk to about writing a curriculum, or somebody to talk to about an evaluation tool. And so if the NMPCTC can help fill those voids and help provide resources, and then to community programs, that's a big part of what we want to do and what we do. And I think the other thing is connection. Like, some rural programs may have an incredible cardiologist in their community that's a great teacher, but no dermatologist. And they need to figure out how to train that. And another community has the opposite situation, has a great dermatologist, but no cardiologist. And so the collaboration between the organizations, between the community programs, increases resource. And I think that's another strategy that we've had, is like, how do we connect to each other and share what limited resources we have to maintain a sustainable program? And I think that's another major structure, because we know the value of these programs, but it's like, how do you actually do it? And so that's part of that strategy.
Really resonates with me what you said about connection, because being a program director is often very lonely. You have myriad challenges that feel like the weight of the world is on your shoulders. You have a lack of mentorship, oftentimes, of just local local mentors, and often get into kind of the what ifs, and you don't know who to turn to. And so having this immediate group of mentors who know actually what you're struggling with, or very similar, is an absolutely incredible resource. And I've used it so many times as a young PD, and I am so happy to continue to contribute in that fashion, because faculty burnout is a real issue too. And so how do we develop new leadership and support new leadership? Because, as you mentioned, administration, sometimes our administrators at hospitals don't always see the value in what we're doing, or don't always agree in the value of what we're doing. And so it can often feel like we're fighting this perpetual battle that's uphill. And despite all the good that we know that we're doing in our hearts, we can sometimes, be on the losing end of these discussions when programs end up closing. And that's sadly the reality in much of rural America, as hospital systems buy up and consolidate. And, family medicine is not the most lucrative of specialties, as we all know, but it's the one that's evidence-based, proven to save lives and add money back into the community, prevent hospitalizations, prevent complications of disease states. And so this is an incredibly important bipartisan victory for our state. Whenever we can land a residency of primary care in a community, we know we will move the needle on public health measures. We will improve the wellness of that community. And so that's why I think we're so passionate about what it is that we do.
I was thinking about when Mac was talking about, like, some other values that we bring, because Mac was mentioned, like, I guess I want to talk about educating the value of primary care to administrators. That sounds crazy, and when we talk about some of the barriers, one of the barriers that Mac mentioned was just like the lack of knowledge and the lack of value that family medicine brings, that primary care brings to a community, brings to an FQHC, brings to a hospital. And there are very lucrative specialties out there, and a hospital will say, wow, gosh, if I train this cardiothoracic surgeon, I'm going to make this much more money than if I train a family doctor. But really, where the rubber hits the road is where we prevent the patients from needing that cardiothoracic surgeon, right? And we keep them healthy and keep them in their community. And I think understanding that value is really important, and then bringing more value. And I think that's one thing that NMPCTC has been able to do. Not only are we training physicians that bring value to the community, and actually, quite frankly, brings revenue to the community. And I hate talking about those kind of things because that's not what it's supposed to be about, even though that is kind of what it is about, right? And but we have the NMPCTC has worked with the state of New Mexico, because the state of New Mexico has a goal of a healthy community and reducing cost and improving wellness. And so the state of New Mexico has worked with the NMPCTC, or we've worked with the state, to really revamp graduate medical education in the state of New Mexico. And we were able to get significant changes to the funding streams using Medicaid dollars and really innovative ideas. But it created a flow of money to hospitals and federally qualified health centers, decentralizing the money that was only going to the academic medical centers and allowing that money to flow into communities to grow residency programs. And I think that's a really good example of reducing a barrier and increasing value. And then when you want to talk about administrators who are really tied to the value they bring, you can say, look at the value that comes with this, you know. And I think those are some extra pieces of the puzzle that NMPCTC has been like front and center with that ever since our establishment. We've been working on some of these things, but it's come to fruition, and because of that, programs are developing, and that I think is exciting, and that's kind of the next chapter of where we're going. I think it's really exciting.
In terms of this next chapter, I mean, what do you see as the ideal goals, the ideal outcomes for primary care in New Mexico, and what the NMPCTC is doing?
Ooh, that's a good question. I would like Mac to answer this. I mean, I'm glad to help, but Mac has assumed the board chair position, and that was kind of an intentional, important thought, because we're moving forward and we need to continue with continue developing the vision and leadership of our organization, and bringing that blood and vision for the next chapter. I think Mac, you're tasked with that, dude. I'm sorry about that. I'll be there to help, but it's exciting. I think the next chapter of NMPCTC is really exciting, and I'd love for you to talk.
You don't move anywhere, John. I'm happy to wear the mantle, if you will. But so happy to have an executive director in Mary Alice, who definitely deserves a shout out, who is definitely a thought leader in this arena, and really helping us as an organization become more effective and more robust. I think we have a lot of victories to build on. I mean, the effectiveness of the organization as an advocacy body, which we didn't really talk about advocacy, but the relationships that Dr. Andazola and others have fostered with powerful allies in government, like the Human Services Department, who really financially steward and care for half of New Mexicans. Really, really powerful ally, and they understand what role primary care fills in that. So really groundbreaking and progressive legislation that allowed us to enhance funding rates and remove one but huge barrier to placing residencies in rural communities. As you alluded to, we have had some hiccups in programs closing. So trying to identify barriers to reopening in those places, and then ensure that some of our new startup programs, like the El Centro Médicos del El Centro program in Española, get off the ground and stay very robust from day one. Exploring psychiatry as an absolutely imperative component to primary care in New Mexico. So really excited about the psychiatric residency program that may emerge down south. Hugely needed again. We'd love to have more engagement from internal medicine and pediatrics, as they play a huge role as well. And so continuing to build those bridges with those departments and identify leaders there about, barriers to escalating the trainees that come out of those programs who are interested in primary care. And then I think where it goes is how do we continue to foster faculty development, spreading best practices, sharing more didactic content. We already do a great job of sharing recruitment strategies and best practices in identifying residents and trainees who are more likely to stay in rural New Mexico, partnering with our relatively new medical college in Burrell. And so I think that there's lots of great work to continue to do. We have more robust staff that has great skill set that I'm such as yourself, Mario, by the way, that I can't wait to see what ideas you bring to the table and continue to kind of build our toolkit, so to speak, because, as family docs, although we are kind of jack of all trades, master of none, we don't get training in, use of social media and recruitment and things like that. And so, we can have this shared infrastructure that benefits all programs and really all residents and trainees. I'd love to share the anecdote that our residency, being in Santa Fe, has a really robust legislative health curriculum and advocacy curriculum. And it's kind of undergoing this renaissance and resurgence as the residents really take ownership over it. And they look at what the consortium's been able to do and leveraging the power of the relationship with HSD and just seeing that the advocacy wins, that spending time in that arena really isn't fruitless like the system would have you believe. Politics is politics and hands off, leave it to the professionals. They really see advocacy as something that they can influence and directly impact both their training but the health of their communities. So continuing to build on that win and help spread that advocacy and legislative health curriculum to all the residents and all the programs. So I think we have a lot of great work identified and no shortage of ways to keep moving. I also would just mention the pathway and the developing recruitment is definitely a huge mission that we have to focus on too, because we want folks from all rural communities to believe that they can become physicians and help them to do that. And so there's lots of things to do. There's no shortage of partners in this work, and just really excited at all the possibilities and how to kind of triage that, I think, is a more important thing that's I'm working on in my mind.
No, I absolutely agree. And it's exciting. It really is. And I agree with the triage, like what comes next. I think it's awesome.
One thing that I did want to ask, and it's kind of this, I don't want to say mantra, but it's kind of this saying that we have, in some of the meetings, and it's the concept of relentless incrementalism. And can you explain what that is and how it applies to what we do at the NMPCTC?
Dude, I love that. Yeah, I think, I don't, it's like my brain isn't working, but I love that term. And quite frankly, it's funny because when I try to use it, people have to remind me of the words. So, but the thing is that it's one step at a time, and it's little forward steps. And, you've heard of that baby steps, but it's relentless. It's not giving up. It's not letting those barriers get in the way. And I think that's really, really important because there are a lot of barriers and we have to redesign the system. I think Mac mentioned early on, the system is perverse and it doesn't support the physicians who make the communities healthier, right? And it doesn't support the growth of those physicians and innovation in those organizations. It supports the opposite, right? It supports people who are treating illness and you get more financial return for illness. And that's not what should be happening. And so we have to be relentless in addressing those barriers and getting more primary care physicians. And it's not just primary care physicians, getting more physicians that the community need. So psychiatrists, pediatricians, et cetera, that are going to keep people healthy, that are going to make a difference in the community. And what's nice, and I love that this was said previously, is the state of New Mexico, HSD, Medicaid, they're allies. And they see the value in exactly what we're talking about. And so it's being relentless in addressing every single barrier and taking that next step, and address that next barrier and take that next step. And I think NMPCTC, where we've come from and where we're going, is an example of that. I think it really has been. I don't know, Mac, did you want to add any extra to that?
It's hard to talk about radical change when you're talking about people's health. And so it can be the easy target to just say, we need to blow up the system. But, there's too much infrastructure that, requires redistribution, I would say. So I think radical incrementalism from a pragmatic standpoint is just how we have to move, right? And we're just relentless because we won't stop until health promotion and not disease, mitigation is what we're all about, right? Until we get upstream of these issues, until we have, a war chest of tools to help patients in health promotion, we won't stop, because social determinants of health and all those things are oftentimes our biggest challenge. And so we just need to keep going until we are better supporting health and wellness in our communities. So
I think ultimately it's the health of the community, and that's what we're looking for, a healthier New Mexico. And so, yeah, I think you got two fighters here that are going to keep it moving forward. But it's not just us. It's not just us. Max said this organization is staffed by some of the most incredible people in the state of New Mexico. I'm really proud to be part of that. Absolutely.
We're getting close to the end of our 10th year celebration. Where do you hope to see the consortium 10 years later?
Wow. Well, I think we talked a lot about that, but I would like us to have established programs in rural communities, healthy programs in rural communities. 10 years from now, we can have demonstrated that we're not only training doctors, but retaining doctors for those communities. 10 years from now, I would like us to have a pipeline developed that takes talented people from those communities and supports them through their education to be educated in New Mexico and to return to our residencies in New Mexico and stay in New Mexico, because we know that will provide the best outcomes for our communities. I'd love to see that, and I'd like the NMPCTC to be the conduit of helping programs maintain that, to be sustainable, but not only sustainable, but to be strong, And I think NMPCTC can help be at that point where they're really a source of resource for community programs, so they can maintain a high quality education for the residents that they're training. That's kind of what I'm thinking.
Heck yeah. I would I'd like to see how we could broaden the consortium, see if we can get, some nurse practitioner training programs represented in here, PA training program in here. If we can be a repository for all the educational opportunities or rotations in the state, we can facilitate, primary care docs that are retiring from a private practice who want to recruit somebody to take over. I see a lot of potential in us being able to consult when communities are in need, and how to help them deliver infrastructure. So, I think that in 10 years, we could have 300 primary care residents training in New Mexico. and hopefully really financially stable programs that are not getting cut. I'd love to see no more turnover in programs, no more shuttered doors, but rather more expanded doors. So, all those things.
Awesome. I agree.
All right, gentlemen, any final thoughts?
I want to say just kudos to Dr. Andazola for his vision. It's a tough concept to wrap your mind around when everybody's busy in their own program. There's enough work to just focus on what your own community is all about. But this is really like a nation leading kind of endeavor here. And the ACGME in the last set of guidelines last year basically said that we want you to start engaging in regional consortia, educational consortia. And guess what? We have a decade's worth of experience in that now. Whereas some other states, they have to kind of come up with this, right? De novo. And so I cannot believe how prescient that group was, and given us just this incredible runway and talent and institutional knowledge that we get to continue to build. So I just want to thank John from the bottom of my heart for being a mentor and a visionary.
Well, my pleasure. And you know what? I mean, since the day you came on board, I've heard your name, and like I think, you're the next generation of this, dude. I'm excited about that. So let's keep building this. I'm excited about that.
You betcha, brother.
All right.
All right. So on that note, we'll go ahead and close out today's episode. Dr. Andazola, Dr. Bowen, thank you so much for joining us today.
My pleasure. It's been
Thanks,
great.
Mara. It was really fun. We'll look forward to the next one.
As the sun sets in our debut episode of Puentes, I want to extend a heartfelt thank you to our distinguished guests, Dr. John Andazola and Dr. William Mack Bowen. Their insights today have truly laid the foundation for understanding not only the legacy of the consortium, but also the promising future ahead. For those of you looking to dive deeper and learn more, I encourage you to visit the consortium's website at newmexicoresidencies.org. There you'll find information on primary care residency programs throughout the state, valuable faculty development resources, and so much more to enrich your understanding of primary care in New Mexico. And don't forget to stay up to date on all things NMPCTC by following us on X, Facebook, and Instagram at NMPCTC. We have many more stories to share, voices to amplify, and bridges to cross together in our upcoming episodes, and we hope that you'll join us again. Thank you for listening, and here's to many more explorations ahead. Until next time, this is Puentes.